We're going to move to Kern County for Lily Alvarez presenting on.
Thank you.
Lily.
Good afternoon, everyone. I'm going to talk a little bit about something different that we're doing in Kern County that has to do with our integration work. And can I just assume? Okay. So let me start out by defining Kern County. Kern County is the size of the state of Massachusetts. That's how big we are. Only about 840,000 people. We have our mental health system is divided into 11 geographic areas just so that we can be present in all of these communities. On the substance abuse side, we use the same definitions of geographic service areas. So we have 11 geographic service areas. And in Kern County, we only have 2 FQHC entities. I don't have 10, I have 2. But they do represent about 27 to 30 clinics. I just asked them the other day, and how many clinics do you have? They are building and building fast with 2014 coming around the corner. We used MHSA because it created opportunities to do this work. It was going to give us the opportunity, if you will, to do integration in primary care. I didn't take integration into specialty clinics, but rather into primary care. It was going to give us the ability to work on developing the skills of the people that were going to work there. There were no prohibitions in the money that I couldn't deliver 2 services in the same day, which means that they could see the doc and they could see me right after that. And that we could both address not only mental health, but MHSA did say that we could also address substance use disorders. And what we did was that it also provided us the time to get ourselves ready for 2014. We had spoken goals. We said we're going to do universal screening, we're going to do interventions, and we wanted to use, if you will, health registries. I'm going to talk a little bit more about that in a second. But I also had unspoken goals. So these are the ones that you know you want to get accomplished, but you don't write them down anywhere. Primary care really doesn't know what a substance abuse counselor does. In fact, they're afraid to recognize that 40% of the people sitting in their reception areas have substance use disorders. And they never knew what it meant. In fact, it was easier to say, I don't want to see that, because if I saw it, I'd have to do something about it. The other thing that we don't know in our own field is what should be the blood pressure cuff. As a diabetic, I will tell you that every 3 months I have to have my blood tested to see what my A1C levels are. What is the blood pressure cuff for alcohol and drug? Is it a clean urine screen? Is it going to meetings? Is it about getting an AA sponsor? What is that blood pressure cuff that we could put on and say, somebody's getting better? The other thing that we wanted to do is that, I don't know about in your county, but we have this huge pit between primary care and specialty, and people get lost in there. Specialty tries to refer over, they don't understand medical necessity criteria for specialty. Specialty thinks it's time for somebody to move out, especially when there are shortages in money. Isn't it time for them to get stabilized in primary care? And people get lost in that. And so what we wanted to do was to use this opportunity to close the gap between primary care and specialty care. The other thing that we wanted to do was to figure out what is this thing called 42 CFR and how does it affect primary care, and how are we going to deal with that? What information are we going to exchange if we make referrals to specialty or vice versa? And what are the rules and how do we take care of that information? And obviously, we wanted to build capacity for 2014. I will tell you that in my county right now, 25% of the population is on public assistance. Gee whiz, and now we get 60,000 more people. Way. So, you know, the first thing we had to do, and 2 or 3 years ago, it was like, what is this model? What would be this model? And I think that in everything that I went to, it was about universal screening. I know people are talking about ASPERT, but it was some kind of screening that would be done. We wanted our staff to be able to provide that brief consultation in the exam room. We're not looking for offices. We're looking for, you're hanging out at the nurse's station, you're available to go in when the doctor needs you, and gee whiz, if you get a space and you can do individual sessions, yay. But the first thing we needed to do is to make sure that every medical assistant knew that you were available. Every doctor knew that you were available. And they don't know you're available if you're sitting in an office with a fern and a lamp. That wasn't going to work. Which means then the kind of personality that you're going to select for this work is really, really critical. And we learned that from somebody in Alameda County. The brief interventions, integrated case conferencing. What did that mean? That mean that what that meant was that I literally put in the contracts that you had to have case consultation. You had to have the psychiatrist, the primary care doctor, and your behavioral health staff all sitting together at some point in time. And what we're beginning to see is actual documentation of these case conferences. They're really fascinating. But we created an expectation in our contracts for this case conferencing to occur. And so what you have is you have formal time, which is really difficult when you've got primary care doctors that have to see a minimum of 20, what's the standard now, 22 patients a day? I mean, it's horrendous. I mean, they have to see them back to back to back to back. So when's that time that they have available? It's a very short consultation, but it's very targeted now. And we wanted to use data. We wanted to be able to show that a patient was getting better. And we wanted to use data to be able to manage the population. What we use specifically in our screening is for alcohol and drug. I brought copies of our screening instrument because I looked at my slides and they were really bad. You know, you can't see anything. But what we did was that we're using the Audit C. Now what we're finding is the Audit C is great for the first screen, but it is not sensitive when I want to screen 3 months later if the framework is in the last year, what have you done? That's not what I want. And so we're looking at, do we modify the Audit C to make it more sensitive? So we're working with UCLA, or are we using something else? And I'll talk about that in just a second. But we used the Audit C, and what we did was that we embedded, we've created one piece of paper. You're going to see it in Spanish and in English. But we put the PHQ-9, the GAD-7, and the Audit C all on the same screen. So this is the top half, this is the bottom half. See, that's why I brought those copies. Let's talk a little bit about information exchange. One of the first things that we immediately understood was that these clients belong to primary care. These are primary care clients, and any kind of notation, any kind of screen goes in their electronic medical record. These are not specialty mental health. These are not specialty alcohol and drug. They don't go into our electronic medical record. This is all information that stays within their own medical record. So as a result of that, what happens is that it belongs to them. They have responsibility for it. They, if you will have to comply with HIPAA. What we are learning, though, is that 42 CFR, once we get to the point of making those referrals back and forth, 42 CFR says that it has to be an individual consent, there's specificity, you can't redisclose the information. And we think that the only thing that needs to be exchanged really is the diagnosis, any labs, and any kind of medication going back and forth. We're using the DD checks to evaluate whether or not there's progress in integration. We're looking at perceptions and attitudes. We've got I'm going to just run through these just real quick. These were the scores from the first year, and every single one of my clinics is moving up in the second year. So the blue just shows the indication of how much the clinics are perceiving their integration efforts improving. We're doing staff perceptions because we want to see whether or not everybody's on the same reality. You can see not everyone's perceiving reality the same way at this point. What I have seen, though, is our preliminary data is now telling us that we're seeing more equalization in this. So if we ever get to present it to you again, we'll show you that more and more of the staff are seeing the same thing, which was important to us. This is what our pipeline looks like. So you'll see that we want to know all the people that came in the clinic, how many of them got screened, how many of them had a positive screen, were they assessed, and did they move forward with some kind of intervention of some sort. This is real quick. You can see PHQ-9 between baseline and time 2. You're going to see that people are getting better with depression, which seems to run about 40%. The GAD is measuring anxiety. We're seeing about 41% of the population screening positive for anxiety. And we're seeing about I think it's about anywhere, that's an average. It goes someplace around 5 to 11% are screening positive on the audit C. We're thinking that we might look at a new screening tool to create the data elements that we want in a registry. If you know what a registry is, it's very open. You can put anything there. Last year, when we first started counting, we had 19,000 screenings. That's a lot of screenings. How do you, you have to put these, okay, in a registry to be able to manage that homogeneous population. So this is what we're considering as some follow-up. We're going to continue to work with UCLA. Just real quick, it's fun being on the forefront, but you have to create a learning environment. Communication is key. So we meet monthly. The physician involvement is really key to that. And so we're using a lot of training events. Just real quick, the barriers are always about the fear of recognizing substance use disorder in the patient, the time for the MD to have consultation, and the conversions of all of our primary care clinics are really changing, if you will, their own electronic medical records. And so you can't install the health registry until you've got, and so they're all moving to next gen in our county. So that'll just take some time. So time is really important. Thanks.